I would wake up. I would literally brush my teeth. I'd have a coffee and I'd go to the OR. And what we were trying to do was trying to deal with emergencies and all those patients injured from before at the same time. So I'd start, I have a semi-elective list of patients with injuries that need to be dealt with, but they've not just come through the door. Because otherwise this backlog, and there are hundreds of thousands of these, will just be completely neglected. And that is kind of what was happening and is still happening.
And what are the consequences of that? So obviously...
Permanent injury, permanent disability, amputations waiting to happen, or deterioration in health such that it will eventually lead to death, and so on. You need to address those injuries. So we had a list where we would plan that list. So we'd go and we'd just get going with our list. Let's say now we've started our first case, 9 a.m. or thereabouts. And then, for example, we hear there's a mass casualty incident. So we stop, we run to the ER, and we help in the mass casualty incident. And here it's just, indescribable. The chaos, the blood, the death, children on the floor, some of them gasping, taking their last breath, some of them with brain out, some of them with bowels out, some of them posturing in such a way because they've got such a severe brain injury.
None of us can imagine what you have seen over the last 7 months. Hearing it is difficult, let alone what you must have seen. So feel free to take a second, honestly.
Children with bullet injuries to the brain. At one point, I had 4 or 5 on the floor, dying, making the choice between who dies and who doesn't, because we have limited ventilators. Child coming in who is about to arrest, and you cannot do CPR because you cannot afford to give 4 or 5 people to one patient in a mass casualty incident. And so the ER doctor says, no CPR in a mass casualty incident. You just have to let that child die. It was horrific. And so we spent our time there, and we would go back and then there'd be emergency surgery. So, you'd have a patient bleeding out, for example. Those were the ones that you needed to do life-saving surgery for. And so we'd jump in those operations. And of course, we're talking about like the Palestinian doctors as well, and nurses and anesthesiologists and, all of them in full swing and full effect, everyone throwing every last bit of energy at them, all the ORs occupied, trying to do our best for absolutely everybody. And then the mass casualty incident will, and also when one hospital might receive all these incidents, what they will do is they try to disperse some of the injured to other neighboring hospitals as well. What was left of hospitals, just to share the load, because no single institution could cope. And so then we'd finish, like the wave of the mass casualty incident would die down, and those that have died, and those that we've saved have been saved. And then you have problems of critical patients, for example, not having anywhere to go because there's no ICU capacity. So they'd occupy an OR. And then, oftentimes they would just slowly deteriorate and then die, despite all of that effort to try to save them.
And tell us why that is, because these are patients who in other circumstances with fairly basic medication could be saved. Is that correct?
Not necessarily fairly basic medication, but just, when you're offering a healthcare system is based on it, fundamentals of, having equipment, having medication, having personnel, a clean environment, a safe environment. When you have a breakdown in any one of those, then the system starts to become defunct. If you have a breakdown in all of them, then I don't know what was keeping the hospitals alive, except for the good faith and the will of the people.
And throughout this, the Israelis are saying that they're allowing aid in, of course. So the limitations on the trucks, which the UN and virtually every single humanitarian organization said was not going in, the Israelis were saying was going in. Did you observe aid, medical aid coming in that you were able to then make use of?
So the WHO would be the ones pushing to try to get aid in. There was also the Jordanians pushing to get aid in. And those were the two only sort of routes for aid to come in. And it was extremely stifled. It was never enough. I mean, I remember when we had heavy bleeding in patients, using a big piece of gauze called an abdominal swab or abdominal gauze, we had to wring it from blood to be able to reuse it. And there were many times where we didn't have drapes or gowns. We'd have to try to think outside the box about how to create sterile fields. We didn't have appropriate antibiotics. We didn't have diagnostics. There's not a single MRI scanner in the whole of Gaza left. It was destroyed. In the major trauma centers such as Shuhada al-Aqsa Hospital, there was not a functioning CT scanner. So these mass casualty incidents, you couldn't get appropriate diagnostics. There was equipment missing, and no analgesics. People came out of major
analgesics meaning
pain-killing medications. People came out of major surgery screaming. The hallways sometimes would be like, honestly, it would be like just screams. I remember thinking and talking to my colleagues at the time, and I said, "Wow, this is it's like a horror show. Just the corridors, people screaming, waiting to have wound changes done." Because think about this, right? You have mass casualty incident. Some people survive. They have horrific injuries. I tell you,
Tell us.
I mean, the chunks of their bodies missing, limbs missing, and huge gashes in their body, and scars from head to toe. And you need to change the dressings on these patients. They get infected very quickly. So they were daily, like 3. So in Al-Aqsa Hospital, we didn't have the main OR facility was due for renovation, and then the war started. So what they had was the sort of the obstetric area where there was 2 ORs for gynecology surgery and 3 delivery suites. Those all became ORs. There were major surgery happening in the delivery room, which is like a cubicle. No lighting. When it was in the summer, it was extremely hot. And you can't fit in any equipment. It was terrible, just a terrible place, terrible situation. Everyone tried. So oftentimes outside the mass casualty incident, those 3 cubicles in particular were for changes of dressings, just constant cycle, like hundreds of patients coming in, because you need to give them some kind of strong sedation. Often we had ketamine or propofol. And so they would do a mixture of those and allow dressing changes to be performed. But you cannot afford to give each patient really the time that they need, because it would clog up the whole entire day, and you have hundreds of patients waiting. So you're just dabbing on wounds really. And by the end of the day, that corridor used to smell so badly because of the air of infection. And I often used to say, man, someone that didn't have an infection, if came in, they would definitely take one on the way out. It was just a horrific situation, really. And don't forget, when you have to do daily change of dressings for some of these patients, and you have to give them ketamine, their tolerance increases, and now you're creating like a different problem of a dependency.
Right.
For so many patients. I mean, there are just so many layers to this that many people haven't even considered or can think of because they haven't experienced it. When you go there and you see it and you live it, and I spent 7 months there, and my last mission was 4 months. By the end of the time that I was there, this was the words of the Ghazans. I was one of them. I was fully embedded in the healthcare system, and I lived like them. And it was an honor for me, by the way, of course. But I really got to see and live and experience what the war meant to so many people.